time.
Thanks.
Next talk is by Dr. Ronnie. He's going to talk about how to proceed when there's structure function discordance and structure discordance. So it's a very, very important talk for all of us, and Ronnie is going to elaborate on that.
Yeah, thank you, Amit, for the invitation, and thanks, AIOS. So I've been asked to speak on two things, and so one is structure-function discordance, and then structure-structure discordance. So what do you mean by structure-function discordance? That basically means that when your optic disc and your visual field don't correspond, you have abnormality on one side and no abnormality on the other, or your OCT and your visual field don't correspond. So if your disc looks clinically healthy with a good clinical exam, a good RNFL, and you see a visual field defect like this, or you see any sort of consistent, repeatable visual field defect, then the most likely example is that there is something else which is the cause. So a normal-looking disc with a definite visual field defect means you have to do a clinical exam, look for any other cause, whether it's on the retina or on the neurological, or in the neurological pathway. That's something that we need to rule out. So why are we then concerned about structure function deficit? Because one of the problems that we often face is there's only structural change. And you need to differentiate between a disc suspect and a preperimetric glaucoma. So I'm going to walk you through a few examples on this. And this is an 18-year-old boy who's a young ocular hypertensive. This is what his OCT looks like. And you can see that there's some superior RNFL loss. His GCC looks fairly normal. That's his panomap analysis, which puts the macula and the RNFL together, and those are his visual fields, which are also normal. So this is somebody who has structure-function discordance, and let's put everything together. He's a young ocular hypertensive. He has a normal CCT. His baseline IOPs are 26 to 28, and he has some structural change present. So in this patient, you have to make a decision on what you want to do based on the other risk factors. Don't go by just the OCT or just the visual field or just the disc. And his risk is probably moderate. He's willing to come for regular follow-ups, and I've been seeing him for the last 18 years now. Last 15 years now, and nothing has happened to him. This is another young glaucoma suspect with a family history of POAG. And if you look at this, his discs, you can actually see that there is some amount of change. There's also RNFL loss in both eyes. Look at his visual fields, absolutely stable over almost 10 years. Look at his OCTs, started off as normal on RNFL, but further down the line, you can see a small change. The GCC, on the other hand, started showing change from the third or the fourth visit itself. So now you have a young at-risk glaucoma patient, structural change more on the GCC to start with. You put the other risk factors into place. He has a family history. He has wide IOP fluctuations and a young age, and you definitely would decide to treat. So when you're looking at structure-function discordance, this is the way you work. What do you mean by structure discordance? And this is again the same issue. We want to distinguish between a disc suspect and preperimetric glaucoma. What this means is when your RNFL is looking abnormal and your GCC is normal, or the reverse. If this is associated with a visual field defect, we are really not concerned because structure function correspondence is there. You're not really so much worried about structure discordance. But if you have something like this, where you have an RNFL defect, the visual field is near normal, and the GCC is abnormal. This is what you call structure discordance. And this is incidentally is the fellow eye of the previous example. So we did a study some time back where we looked at patients who we thought were disc suspects. So 3 glaucoma specialists assessed all the discs without any other information. And they all had normal fields, and we classified them as preperimetric or as just disc suspects. And then we looked at the OCT without the summary parameters, just the printouts and the maps, just the maps in fact, and classified that as abnormal or normal based on the pattern. And we compared this with the machine-based parameters as being classified as normal or abnormal. And we were actually quite surprised because the clinician's discrimination of normal versus preperimetric, you can see that all the RNFL and OCT parameters were statistically significantly worse in the preperimetric group, the ones that we thought were preperimetric. What was also interesting that the clinical OCT classification did as well or better than the machine OCT classification in this group. And when you put this together, the likelihood ratio of a positive or a negative test was such that if you look at only a clinical OCT, which the clinician considered abnormal, you increase the chances of that patient having preperimetric glaucoma by 25%. If it was negative, you reduce the risk by 25%. So it had actually fairly good discriminative capacity when you looked at the maps more than just the numbers alone. So I'm going to walk you through a few cases now. And this is somebody whose discs look like this. OCT looks like this. You can see that there's a RNFL defect, but the GCC looks normal. So here, the RNFL defect is narrow. You can see that over there. In the more peripheral bundle, it corresponds to the most suspicious area of the disc that you're seeing here. And therefore, this is somewhere where I would ignore the normal GCC and say that this is somebody with an RNFL defect. This is somebody with probably pathology, and I would treat them accordingly. So here you have structure discordance, but you have something on the map which tells you that there may be something wrong. When you have a very narrow defect, it may not cause enough damage for you to meet statistical significance, but looking at the map is important. This is a second case, and here this is what the discs look like. There's some peripapillary atrophy, there's a bit of a tilt. This is what the RNFL looks like. And here you can see that the GCC is showing you some change. The RNFL parameters are absolutely normal. And when you look at the panomap, again, you're not seeing any connection between the RNFL and the GCC. And this thickness is annular. Annular thickness thinning is unusual in glaucoma, and I would really not be too concerned about this and leave it the way it is. This third patient actually had congenital glaucoma. He's 20 years now. He had surgery 20 years back, and this is what the discs look like. This is what his fields look like. And this is what his RNFL looks like. The right eye is fairly okay. The left eye, you're definitely seeing some defects, and both eyes, you're seeing some changes at the macula. You put this together and look at how the panomap behaves. So you're seeing something little bit on the RNFL there, and it extends, the same thing extends to the macula. In the left eye, you can see it extends to the macula. So when your panomap actually follows the same pattern, the RNFL extends to the macula, then it's more likely that this patient has an issue. You would have ignored these little defects in isolation, but when you combine it with the GCC, it's important. So it's important that you look at the combined GC and RNFL deviation map when you are instead of looking at it in isolation. So this is an 84-year-old pseudoexfoliation, ocular hypertensive, post-trab for the last 10 years on 3 drugs. The RNFL looks normal, the GCC looks abnormal, and it looks sort of annular, but if you look at these fields, they're okay and they've been okay over time. But what's important here is this temporal raphe sign. If you see this abrupt sort of cutoff on a GCC, that is usually indicative of glaucomatous damage because you're seeing a hemifield difference between both hemifields, and this is fairly typical for glaucoma. So when you make